Those of you joining us for the first time, QI Power Hour is a free monthly webinar learning series hosted by HQC. We bring together improvers from a variety of sectors with an interest in improving health and care and to learn more about quality improvement related topics. I am joining you today from HQC's offices in Saskatoon on Treaty 6 territory and the homeland of the Métis. As a provincial organization, we also serve peoples living on lands that are parts of Treaties 2, 4, 5, 8, and 10 as well. We pay our respects to the treaties that were made on this land and acknowledge the harms and mistakes of the past and those that continue to this day. And we are committed to moving forward in partnership with Indigenous nations in the spirit of reconciliation and collaboration. And I think part of that commitment is supporting improved primary care, the foundation that supports better health for all, which of course we're going to hear a little bit more about today. You can see past QI Power Hour sessions on our website at saskhealthquality.ca. So you can see a couple of examples on our screen here. Please feel free to visit the website and listen to today's session or other sessions that you may be interested. And also, while you're there, please sign up for our QI Power Hour email newsletter, and that'll give you notices about upcoming sessions and details on how to register straight to your inbox so you'll never miss a QI Power Hour session again, and you can sign up for that on our website. We are very excited to see the continued growth of QI Power Hour throughout our home province of Saskatchewan, across Canada, and around the world. So thank you so much for spending an hour of your time with us and for your commitment to ongoing learning and improving the systems that you are each a part of. Today we're using WebEx for our webinar. We want lots of engagement and participation as it goes on, and you can do that through the chat. So most of you probably know how to do that already. If you don't, there's a little speech bubble looking icon in the bottom right-hand corner of your screen. You can click on that, share your questions, your comments, your ideas in the chat, and please feel free to do that as much as you like today. Please be sure that you send your message to everyone so that we can all see it. And I will also be monitoring the chat for questions as we go, and we'll have some time at the end, and I will pose that to our speaker at the end of the session. So why don't we practice right now, if you don't mind, letting us know where you're from, where you're joining us from today, sorry, in the chat. And without further ado, I am so pleased for today's session to welcome Dr. Emmett Harrison to tell us about his adventures in quality improvement in primary care. Dr. Harrison is a family and emergency medicine physician from Swift Current. He is a champion for quality improvement in various roles. So he has formal training in quality improvement through a Master of Health Science in quality improvement. And he plays many roles in the system through Patients Medical Home, the Pharmacy Care Pilot, the local resident scholarly project lead, and he's also a good friend of the Health Quality Council. He was the brave pilot physician that helped us test the quality improvement or QI in clinics program. And he's returned to that program to be a QI mentor, which we also very much appreciate. And we're very much looking forward to hearing about your adventures and improvement in primary care today. And I will, without further ado, pass it over to you, Dr. Harrison.
Thank you very much, Tracy, and thank you to Health Quality Council for having me. It's quite an honor to be here. I did this presentation for my wife, and essentially she asked me why I had this picture, and I said, well, it gives context to where we live and work, so southwestern Saskatchewan, and maybe I'm a bit more relatable with a dog in the picture. And she said, this looks like it's a dating profile picture or something like that. So I also have to add that I've been happily married for 1.5 years, so that's part of the bio too. Like I said, I don't have anything more to add to the bio here, so I'll move forward. Thank you for having me. So I've got 3 objectives. One is I want to inspire you guys to maybe use some similar quality improvement practices in your collaborative teams that you're working in. I want to be an advocate for the patient's medical home, and one that includes continuous quality improvement. And finally, I want to tell you about the opportunities in the province for leveraging some of the quality improvement programs and education tools. So I'm going to talk about 2 pilots that I'm involved in. Pilots are new novel, sexy. So hopefully that's what's going to dazzle you guys today. But I just want to say that a pilot and a continuous quality improvement are not the same thing. So a pilot project is something that new, novel, that's they're trying it out for the first time. Continuous quality improvement is a systematic improvement of processes and systems. It could be that we do the old process. It could be that we do something new. It could be something that is the same, but we're limiting variability within the system. So it encompasses a bit more. A pilot project can include continuous quality improvement, and that's what I'm going to talk to today. So, a leader or a speaker on leadership, Simon Sinek, always says you got to start with the why, give the purpose. So, the patient's medical home pilot. So, our goal with this is improve access to primary care. It's very difficult to get a family physician anywhere in Canada. Our community is not alone. Physician and team satisfaction. Physicians are burning out. There's a lot of work that we're doing, and we're having difficulties keeping up. And then the patient experience, we want to improve. How are we going to do this? Well, creating a collaborative and high-functioning interdisciplinary team in an outpatient family medicine clinic, so out in the community in Swift Current. And finally, what are we going to do? Well, we've received some funding for a licensed practical nurse, a registered nurse, and a social worker at the Associate Family Physicians Clinic. The clinic that I work in, there's 10 physicians there. And we've got 2 dedicated physician leads, one of them being myself. So what is the patient's medical home? Well, it's the vision for the College of Family Physicians of Canada. They've got 10 pillars. They've graphically made it into a home to show that this is all the things that we're working on to improve the patient experience, the patient's home. One of the things that you may, or pillars that you may see is comprehensive team-based care with family physician leadership. That is one of the essence of what we're doing with the pilot. And of course, if you're improving comprehensive team-based care, you're likely touching upon all of the other pillars. So the litmus for a pilot project being having the ability to be a continuous quality improvement project is emphasizing quality. So there's 6 different elements. This comes from the crossing the quality chasm. This is something that was initially, I guess, coined in 2001. But essentially, if you are doing a pilot project and you feel that it's going to affect one of these indicators, it has the potential to be a quality improvement project. So safety, is it effective, patient-centered, timely, efficient, equitable? For example, with this pilot project, we feel could our interdisciplinary team obtain better health outcomes for our patients? Could co-locating different team members using one electronic medical record allow for health services to move more smoothly? So is it more efficient? So definitely lots of questions for quality with this pilot project. So in fact, it was a good quality improvement project as well. So there's 3 things that you need for the model of improvement. You need an aim or a goal, you need measures, and you need change ideas. So for this pilot project in particular, our aim was improving primary care access with this model. Our measures are going to be looking at physician visits saved, patient-reported outcome measures, and staff satisfaction. And then the change ideas is a transfer function, some things that physicians were doing previously that allied health professionals should be doing or likely can do better. In this, we're also making a triage system, altering our booking process, and improving the flow of patients through the office. So if Dr. Gary Gruch, my master's supervisor, is here, is going to say that's a big aim statement, but I think it's got to be a bit more all-encompassing for this. So bear with me. We wanted to save 500 physician visits in 6 months using the Patient's Medical Home pilot project, transferring physician tasks to the collaborative interdisciplinary team. Meanwhile, we wanted to make sure that we are maintaining, improving the patient outcomes and staff satisfaction, in which we use 2 different questionnaires that's going to be pre and post. So let's talk about the first cycle. So it was staged with 3 different health professionals that we've added to our practice. The first was a licensed practical nurse, and that was on October the 6th, integrating them into our office and providing with different tasks that we could provide for as a function from physicians to the nurses. For example, how we determined physician visits saved would be 2 immunizations. Physicians previously at our office gave all immunizations. Removal of sutures, something that we did for all of our patients. Following up for blood pressure. So whether they started a new medication or stopped one, they would review to see how they were doing in a week's time or 2 weeks' time. Some positive results that were not appropriate for reception to call patients about, but perfectly acceptable for a nursing staff to educate patients about, have offloaded too. And then co-booking visits for things like chronic disease, new patients, prenatal visits that previously took up a large chunk of time, whether it was half hour or more with our physicians. Then we onboarded the nurse, registered nurse. As you can see, they have a bit of it more expanded scope. So they added a few more things, like the ability to do pap smears for our patients and averting patients in the triage that likely didn't need an appointment, just needed task completed. And then finally, social worker, which it was difficult to find a direct relation of a task that a physician was previously doing, but a very important part of the team, more looking on diverting paperwork that physicians were doing, such as disability tax credit forms and patient satisfaction. So doing needs assessments on high frequency care users at our office. So those are the 3 different, I guess, PDSAs that we had. And essentially, we hit 200 on December 29th. That was a big kind of like a shock moment and actually motivator for our office. And then more recently, 325. So we're 2/3 of the way there, and 2/3 of the time has elapsed. So we've got another 2 months to get to our 500 patient visits saved. So we're quite excited about that. And I just want to speak to the balancing measures, which is staff satisfaction, patient reported outcomes that we are tracking as well. So this is a PDSA within a PDSA. Very meta, I know, very meta. But essentially, we've got nursing cancellation list triage. So this is specifically for the RN that we had on board into our office. We had the change idea. We have unnecessary visits. Can we divert some of these to the appropriate area, the appropriate professional? And we want to see urgent cases, but we don't know how. Can the nurse assist us with this? So essentially, our plan was that the nurse would look at the cancellation list, phone back these patients, and essentially triage them on an urgent basis or divert them accordingly. So we elapse half an hour or more to complete this task. An urgency classification was made, and then there were some same-day visits that were reserved that patients would be slipped into based on the triage, or within our electronic medical record, tasks were created to physicians or other health professionals. And if there's things that were questionable, well, there was a doctor that was assigned that was available to them to answer questions and help improve their skill level on triaging these things as well. So study, we had weekly audits by a family physician, reviews all the cases briefly to see, is there anything that can be tweaked. We got huddle feedback, so there's touch points, patient feedback, anonymous staff feedback. For example, one of the doctors wanted more detail about urinary tract infections to triage the urgency. And the nurse themselves identified that they were previously public health nurse, and that they could, when there was a request for travel vaccines, they could do the education and likely do most of the visit start to finish. Actions, well, changing the nurse triage algorithm, refining our communication, altering the booking process are all things that have happened continuously. And for example, we used 811 protocols and a standard macros template. So push a button, boom, all the questions about urinary tract infection that the physicians want to know about are right there to be asked for the nurse. And, the nurses internally sending requests and descriptions about patient requests so that scripts can be just sent off to the pharmacy right after. So it's really streamlined that process. So what are some tools or things that are adjuncts that help with the QI process? Well, a team huddle. So we reserve 5 to 10 minutes in the morning for all of our staff, office manager, reception, social work, physicians, nursing, etc., to talk about the day and help the workflow. This is our first meeting that we had. That's we got this picture there. You can see me in the back giving the first huddle. We have a script. So there's 3 parts to the script. The first is kind of a check-in with the team. Who's available? Who's not here? Who's going early so that we can divert workflow. A lot of the times it's those doctors that are on obstetrics that we can anticipate are could be called out. This is where we identify those things. Reviewing the schedule. So which patients are in, there are specific needs of that patient, are they grieving, etc. And this is where we talk about improvement initiatives every day. It's a top of mind. We've got our change ideas that we're talking about and working on. And then once a week, we reflect on how did the week go? Is there anything that we want to change for the following week? So daily visual management board, we've got a board that helps direct our huddles. So it's a reference for what initiatives that we're working on and kind of talking about the champions and things that people are doing great. It's also right in the core of our office. It's fully transparent to our patients so they can see what we're doing to improve their care as well. We've got feedback systems, which are another important tool. So essentially, anonymous feedback is important because at the huddles, not everyone wants to speak or speak this allows them to speak more candidly as well. So we've got QR codes at each workstation that we review on a weekly basis to improve things further as the physician leads. There are work standards. So standard work is a very important concept in QI. So if we want to limit mistakes, if we want to have a reference for training new individuals, this is the way to do it. And so we have this available at each workstation as well with all the work standards. They're updated on a continuing basis and they're reviewed by those that are completing the role themselves. So for example, the RN in this case for the cancellation list triage. Okay, QI doesn't come without its challenges. I'm going to highlight one of the challenges in this one is the social barriers. And let's talk about social barriers and how to break them. So, for example, team buy-in, initially we've got this huddle and a script and people are, thinking, okay, this is, people are telling me how to change my job. I thought things were fine to begin with. So one of this huddle script things that we talk about each day is, are there opportunities for opportunistic care for our patients? Is there things more that we can do to improve their experience that day or add on to their care? And staff had stated, we're already doing everything we can. And so one of the solutions that I had was to turn it around. Okay, if you were the patient, what would you want at your care visit? And so centering it on the patient rather than about the frustrations with doing things differently. The arrow here is what's in it for you. So you may pick up on some let's say colon cancer screening as the medical office assistant that we didn't, and that might result in catching something early and improving patient care. So what's in it for you is being that leader, being someone that's going to improve a patient outcome. And then highlighting champions. For example, our nurse started on her own looking at the schedule to look at the young adult population if they've had their HPV vaccine or not, and asking them if they wanted it. So took that opportunistic care onto herself. So I highlighted those things to say these are things that people that we've identified in this that's working. Perceived increased workload is something. So one of the doctors said, I don't think they have time for training a nurse for integrating them into a chronic disease visit today. I'm busy today. And my response was, okay, how about you get that nurse just to sit in on the visit? That's it. They're not going to change your workflow. They're going to sit in and they're going to listen. And eventually, these co-book visits are going to decrease the time. So I know that you're busy today, but this is going to help you in the future. So focusing on two different things is starting small. So just observing, it's as simple as that. And two, that you want to reflect that if you think this is increased upfront, it's going to improve you in the long term. So let's talk about some of the successes of this. So I think it was a big highlight of 40 visits in 1 week that was saved in December. I can tell you last week we smashed that at 47. And then the 200, I think, was like a big spot that we got to, and it really motivated the team as well. Some feedback from the staff. So a doctor said, I feel like I got my paperwork done early this week. Excellent. We've got reception saying, we've got improved access for pap smears because a nurse is doing it. This is really going to help things out for booking. I can't believe that the cancellation list that we've got through it, that was something reception said. We've got a doctor saying, I don't know why we gave immunizations in the first place. And I agree with that statement. And then we've had a nursing staff say, I love working with them, meaning the medical office assistants. So they love the new staff and working well together. Okay, so we got through one new sexy pilot. Let's turn to another one. So we focus on under the same roof. Now let's talk about in the same neighborhood, working together. Something called the pharmacy care pilot. So starting with the why, the purpose. So again, improving access to primary care, shortage of family physicians, physician and pharmacist satisfaction. So, pharmacists want to, improve and do different things, have a variety. Physicians are burnt out and would like some help. And then patient experiences. The how. Utilizing a collaborative practice agreement to successfully transfer function from 3 physicians in Swift Current and pharmacists at a local Shoppers Drug Mart. So that is the how. And the what? Well, a government-supported trial of increasing the scope of practice for pharmacists. So I don't know, I'm not sure if everyone knows, but essentially just like many of the other provinces, sometime this year, there's going to be a formal expansion of scope for pharmacists. This is the way to trial it in a phased, measured, and collaborative way before it goes out larger. So as it was alluded to earlier, I'm doing a master's of quality improvement. My supervisors are Dr. Gary Groot and Dr. Tracy Carr, hopefully are here today. So essentially, a pilot project does not mean continuous quality improvement. Yes, this is a change, but I want to focus on what things can we do better. One of the things that I did as a class or course project currently is I want to increase the annual uptake of prevented chronic of COPD, chronic obstructive pulmonary disease assessments within a year. And as you can see there, there's the ethics approval for this project. So the problem was we identified that there's about 214 patients at our office that have a diagnosis or suspected diagnosis of COPD. Okay, that there is something called the Chronic Disease Management Quality Improvement Program, which is a comprehensive assessment with different indicators, had only been done only eight of our patients in the last year have went through the formal assessment. Yes, there was assessments and check-ins at different times, but not to the indicators that we should be striving for. And so if there's a lack of routine care for our COPD exacerbations, and COPD, it can lead to increased exacerbations or hospitalization. Now, I think there are more problems. Essentially, these patients have multiple comorbidities and they're coming to their family physician with 7 or 8 issues. So doing that full assessment can be difficult, but we wanted to strive to improve that. So reflecting back, can this pilot project be a continuous quality improvement initiative? Well, I think that we're talking, is this effective? Pharmacists are already doing exceptional drug status, coaching patients on their inhaler technique. They are, in my opinion, COPD experts already. So this is the perfect disease to start with. Can they be providing more holistic care for them at times that are more appropriate? Is it more efficient? Their pharmacy hours are more extended. We're getting renewal prescriptions when they can prescribe these themselves. So we're asking these quality indicators. So I think this is a good QI project for sure. So our aim statement, well, we wanted for our shared patients between the Associate Family Physicians Clinic and Shoppers Drug Mart, we wanted to increase 30 visits within the next 6 months, okay? And we want to make sure that the patient experience was similar or better than with a physician. That's our aim statement. So the model for improvement. So fitting this pilot, what are the 3 things again that we need for a QI project? Well, we need a goal, we need an aim, we need some measures, and we need some change ideas. So our aim was to increase by 30 visits in a year of going through all the indicators. And we wanted to make sure the patient experience was maintained. The measures, so there are COPD indicators that are already pre-existing in our province that we wanted to hit. We wanted to make sure that the treatment guidelines are being hit as well, that the patient experience, there's a survey to make sure they're liking this experience. We're looking at other things like ER visits and hospitalization frequency and provider satisfaction. Change ideas are going to be changing the function, transfer function from physicians to the pharmacists for these comprehensive assessments, and providing a new means of communication. So instead of faxing, using something called interoperability to its full capacity, and then hopefully coming up with a toolkit that these practice agreements and measurements can be lumped into to help scale this in the future. So let's talk about the first month of COPD specifically. So we're going to exercise this agreement that we have, that we're going to get feedback every 2 weeks from the professionals, that's the physicians and the pharmacists involved, and we're going to obtain measures every month to see how we're doing. Well, 7 patients for COPD specifically in that first month had a comprehensive review. How did patients know about it? Well, there was a big radio, news, online broadcast from the pharmacy care clinic opening that was covered by different media. And then there's word of mouth. So physicians to their patients, pharmacists to their patients, patients to one another. And we were able to connect once, at least, in that month to talk about how things were going. So what were some things? So when we looked back at, okay, what are some factors that have affected this process? So providers are on holidays. How can we have meetings under other means of communication, such as phone calls, emails, to help routinely to help with this? Patient factors. We found that those that had purely COPD were more up to uptake this than having multiple comorbidities. That system factors, so interoperability not working and having to go to fax instead, spirometry software needing upgrading, missed asking about depression, anxiety screening, and action plans. So we picked up on those things, that integrated them in. So actions, we are troubleshooting our EMR, that transfer of data. We are identifying needs for probably more diseases that need to be reviewed by the pharmacist as well, and suggesting that there be different things entered into a template for the screening. Busy schedule. Okay, I've got some questions already rolling in, so we'll reserve those for the end. So let's talk about a team charter. I want to talk about this specifically because a collaborative practice agreement is just that. This is what we would like to do, or this is the standard that everyone has signed their name to. For example, there are things that pharmacists are already doing that they're going to continue to do. There are things that physicians are doing and are going to continue to do with regards to managing patients with COPD. Then there are the things in the middle. So the things that probably pharmacists are very good at doing. If but we must agree to support them in this. And so, for example, initiating, stopping, or modifying medications, uh, doing counseling and providing prescriptions for smoking cessation, um, doing assessments for spirometry that are then read by the physician. So those are some things that we've agreed. The pharmacists are going to be doing in this agreement purely those things, and then the physician has a process of reviewing these things or being available for questions. So medications. So we get down to the fine details on what medications can be prescribed, what medications have to already be prescribed that you can modify or stop, that a pharmacist can initiate, etc. We get down to the urgency level of the patient's presentation, down to how the physician and pharmacists are going to communicate, whether it's fax or phone call, and what's the expected turnaround time for returning those things, all signed to an agreement. So I just want to speak to the one, I guess the challenge for this one specifically is measurement and communication. So we strive to have the best communication, and that was going to be that automatically the information from shoppers and associate clinic go to eHealth that's available there. So if there's a change in the provider, whether a pharmacist or the physician, that this information be available online in their eHealth provincial record, so that someone else can manage it. And that let's start when we've got this project to integrate that. So there've been some IT difficulties with that, so we've gotten back to the fax, but it shouldn't halt like our process and trying to gather data and to move forward with that is what I wanted to represent with this slide here. So all the transfer functions in that first month, how did things look? So COPD was only one disease that we started with. There are 7 patients. INR is something that we've integrated that haven't had any uptake of patients yet. Hypothyroidism, 11 patients for a transfer function. And the biggest one, which is led by the psychiatrist, and a lot of these are patients without a primary care provider, is prescriptions for medications for anxiety and depression. So a big uptake of those patients, but also a big need. So what is the success other than 3 grown men being able to cut a ribbon by holding the same pair of scissors? The success is that this is the start of a collaboration between community pharmacists and physicians, and using pharmacists to the top of their scope, I think is a big thing. So this was on December the 9th that we had this, and that's our local MLA on the right. So some provider feedback. So I've had requests for patients in the community to be part of our practice for the sole reason is because they want to be part of the pharmacy pilot. So we wanted to start small, and just with our patients that we were already managing, hopefully that this grows into something bigger, more physicians and pharmacists are on board to do similar things. We've had another physician say, I did not feel any burden from the pharmacy contact whatsoever, and I feel like we have the capacity for more disease to transfer function. We've got pharmacists saying that it was a lot of fun. They liked having the deeper conversations to share with their patients, and that can't happen in a typical 2-minute window. We also had a pharmacist say that they believe that it was when they needed the care most was when the pharmacy, so it was beneficial that they could provide that to them. And then another pharmacist saying that they're getting requests for more patient diseases to be managed at the pharmacy all the time. And so lots of really good feedback from all the providers. I think it's been excellent. So I got through both of those pilots. New, sexy things happening in Swift Current. Hope you guys are encouraged to come down and visit our beautiful community. I just want to talk about the resources now. So QI clinics. This is where I found my love for quality improvement. It's free. It's 4 months of a training. It's about 58 accredited CME hours. You can come as a family physician and bring your staff even, so you can all learn together. Typically there's 1 to 5 staff. There may have been more in other groups. You get coaching, you get the tools, you get patient partners, patients to help with the process of improvement. You get the connections in the province. You get assistance with your electronic medical record and altering things to help with quality improvement. So integrated within QI and Clinics is Estimate EMR program, or you can do it in isolation. It's a paid program. Everyone should be using it, optimizing their use of the electronic medical record. And then if you're a nerd like me, and if you previously had interest in the CQIP program, Clinical Quality Improvement Program, it's now offered asynchronously with the U of S as a master's program. So I'm doing, a year of learning content and then a thesis project next year. So essentially, if you're a nerd and you want to optimize your QI, there's that as well for the keeners. Integrate learners. So I serve the role in Swift Current as their family medicine residency program. I am the improvement project lead for the residents. And so they're focusing QI and practice improvement already. So if you've got improvement ideas, let's say that for example, myself, I had a Dean Summer research project with a medical student and a resident continue on a project that I did in QI and Clinics. So you can teach them what you know and continue on those projects that you have for improvement. I think that's a really good way to get learners involved. And so I just want to remind everyone to vote for the SMA within the new contract that they're looking for family physicians. Essentially, there is something carved out for innovation and quality improvement. And I think that's something that I really took away from that. So let's summarize things. That was a whirlwind. So 3 QI necessities. So aim, measurement, and change ideas. I want to change it to a quality aim is something that's a necessity if you're doing a pilot project. Measures and change ideas, those are all necessities. There are helpful tools. A team charter, some people call them an A3. In this instance, it was a cloud practice agreement. Having daily visual management, having touch points or team huddles, feedback platforms, standard work, all some QI tools that are helpful. Break social barriers. So for example, if you're meeting some social barriers, stick to the principles, shared vision, what's in it for you, win-win, and highlighting the champions. If there's data obstacles, shouldn't halt QI. So for example, our interoperability not working. Well, there are simple tallies or informal communication that can capture helpful information as well. Just start the process. That's all I'm saying. And then there are QI supports and education in the province, whether it's QI in Clinics, the Estimate EMR team, or QI Masters at the U of S. Take your change ideas and put them into action. And then lastly, integrate the learners. They're going to be the next generation of nurses or family physicians. And if you include them in the process now, it's just going to continue with the QI change mindset. So I want to acknowledge a few different people. Saskatchewan Health Quality Council, first and foremost. Dr. Baylor from the Sylvan Lake Sylvan Family Health Center, who shared a lot of his work standard resources for integrating into our clinic. My staff at my office for being part of the change process and being the real champions. And then Shoppers Drug Mart and Swift Current, their staff too have been change champions. And then Doctors Gary Groot and Tracy Carb, my supervisors for my master's program. And questions? I know you might have some questions that I'm not able to answer today, but I've got my email here and a couple social media platforms. If you want to reach out to me that way, I'm happy to answer.
Great. Thank you so much, Dr. Harrison. I've just been so much enjoying so much hearing about all the great work that you and your team have done in your clinic and the improvements in care for your patients. It was really exciting, and I think you've sparked a lot of thought and questions among the audience. So I'm going to get right to some of the questions in the chat. Please feel free to keep submitting if you haven't yet, and I will try to get to as many as I can with the time that we have left. So one question out there is, do you have patient-family partners as part of your QI project? So I think you mentioned that a little bit. Can you say a little bit more about how they're involved with the work?
Yeah, so for the patient's medical home, our patient partner has primarily been part of the communications team. So we've got one locally that helps us. How do we get the message to our patients? And also, this patient's medical home is going to other offices in the community. Uh, Keep the messaging positive, centered to patients so they understand what is happening with these changes. So some recommendations they had was actually having on the hold line for our office talking about the patient's medical home and what we're doing at our office for them currently. So some cool ideas that are been integrated. And for the pharmacy pilot, that patient questionnaire for their experience, we had 2 patient partners assist in the creation of that. So we've had them have patients partner involved, and it's very important to do that too.
Great, thank you. Another question about, and I know probably many of us were wondering this, is you're probably not just sitting around most of the time without things to do. So how did you fit all of this work into your already busy schedule? Did you have time released from your other responsibilities? And do you have, tips or recommendations for others about how they integrate improvement into the work that they do?
So I think already having some of the, I guess, tools or background was helpful. So if you're going to get continuous medical education credits, do it in the QI and clinics, get the support and tools. You can't just start it on your own. You need some support system. So there's that makes it easier. So if you already got the knowledge and the skill set, you can integrate it quite easily. Other things, yeah, I'm not doing this in isolation. There's 2 of us at our office that are physician leads that are taking this on together. We've got the rest of our staff kind of helping do other things. For example, I do some addictions in over the 6 months, I've had someone locum and do some of the work for me. So there is a bit of give and take with anything that you do to integrate these things. But I think that they're important and they're timely. So we should make the time available to work on these things. It's gonna help things in the long run.
Thanks so much for that. I think one of the things that stood out to me in the examples you shared was how you integrated improvement work into your day-to-day. So it's part of your daily huddle. You talk about what could we be doing better, what could we try, and how you broke things down into kind of smaller, more manageable chunks. Like, okay, I wonder what will happen if we try this. Well, let's try it on a couple of patients and see how it works. And so I think that also helps too with it doesn't feel so daunting that way. Is maybe let's just give it a try on a patient or two and see what happens. I think those are really helpful too.
Start
Um,
small.
yeah, exactly. Another question here about who is the employer of the nurses and social workers on your staff? Is that the SHA? Is that the clinic?
That's correct. So Saskatchewan Health Authority, that's their employer. They are renting space out of our office essentially, and that's how they're housed.
Great. Okay. And another question here. Oh, there's more in here. Okay. So one more. Can you talk about the collaboration on patient records between your clinic and the pharmacy? So I think you mentioned that a little bit. Your
Yeah,
diagram shows what looks like an inability for the pharmacy to send EMR data back to the eHealth repository.
yeah.
Is that the case? And do you feel like that's a problem that's reasonably solvable?
Yeah, so we're working on it currently. Essentially, if there's any physicians are on there that are using the CDM QIP forms, essentially they're flow forms that are in our Curo EMR that there's tick boxes and things that we can write into them. Those, if you upload them, will go to eHealth repository. That information can flag a signal to the pharmacist to say, hey, this has been uploaded. Let's review this. So they get the details from our visit. It's just working in reverse. So there is no CDMQIP form or process for pharmacists currently, but there is a way to get EMR visit data from them to the EMR that will signal our EMR for that information that's there. That communication is currently, we're working through it. If it works, this is excellent. So, there are patients, just like in the part of the pilot where they have anxiety and depression, they have no primary care provider, just a uh, psychiatrist that's available to the pharmacy for questions and to help things. Those unassigned patients, well, they might have a different provider like in the future, or the provider may switch. And so that information in a place where the health information can move a bit freer than one isolated EMR to the next, I think is the way of the future. It's going to be excellent if we've set up this pilot project. We might as well use the best process available. So we're going to continue to strive for that.
Great. So it sounds like, you're making some inroads there, that it is a problem that is solvable, maybe in chunks, but that you're getting there. There's a couple of comments here just giving you some big kudos, and I think there's probably a lot of us thinking that right now. Really appreciating your championing of improvement and saying Swift Current is very lucky to have you. I think the part of the comment that stuck out to me is a forward-thinking provider that sees the value in patient experience and their interactions with the most appropriate provider. So please continue to do that work and continue to share your results and inspire others. Also a comment here about the SMA's tentative agreement with the Ministry of Health and wanting to remind folks there is funding in the agreement to support team-based care, quality improvement, and a new transitional payment model for family physicians, and that the SMA's EMR team is available to assist with meeting your EMR needs. And I know you mentioned that. That's something that all physicians should take advantage of. A question here about LPNs now being in a more front-facing role. What sort of cultural competency training have they taken to ensure they're providing culturally safe care to diverse populations?
So I think there is uh, training for all SHA staff for that. So it's going to be no different. They're an SHA nurse already. And so I think like if there, is there something specific to our office? Well, I think it's going to be no different whether they are working at the hospital like this or, at the Meadows or other places in our community already. So if there are any SHA people on here specifically, maybe they can speak a bit more to that. But essentially, I know that I've done my training and it's like a online CME and modules, and they have some more training opportunities annually for that. So
Great. Okay, thank you. There's some shout outs in here that I think are worth mentioning, so I'm going to read them out. It says a huge shout out to Curtis Newton, an SHA primary healthcare director, and Liz Racco prior to Curtis for their work done on these projects as well. It has not been small tasks to implement, and this person wants to congratulate them on behalf of the team because I understand they're very humble people. But it just demonstrates, it's a team effort, right? There's lots of folks involved in making this happen.
I want to echo that as well. They have been doing lots of hard work, and some people in isolation that I should be thanking. They started all these change ideas. I'm just, I'm essentially just a part of the process here. So they came up with the big ideas to begin with. So
Um, so we have a few more minutes. If folks, if you have a burning question on your mind, feel free to pop that into the chat. But one I might ask while I'm thinking, and I really appreciated how you talked about the pharmacy pilot, because I think that's a really great example of uh, really focusing on team-based care and who is the best person to provide a particular service. And I know that can be challenging sometimes when you have new team members working together to kind of build that trust between team members in each performing those roles or in performing new roles that maybe they hadn't before. So I just wondering if you want to say a little bit about how kind of you work to build trust between your team members in taking on those new roles.
so essentially, some of the pharmacists I've spoke to on the phone before prior to this pharmacy project, I didn't actually know them until working together. So I think taking that initial step to reach out, to get to know them, have meetings, these are very qualified professionals, very nice people. I think just, reaching out a hand and starting the work. Essentially, as you work together, you're gonna build that relationship with one another. And so I think my suggestion is just to reach out and to start, raise these questions that you've got a common vision for, and that's patient care, and hopefully, you know, just with time and working to get together, you'll build that relationship.
Thanks for that. Yeah, I think, something that we're continuing to learn about improvement here at Health Quality Council is how important relationship is, and that it is an outcome in and of itself that leads to better and improved care for people, is that strong relationship. So it's worth the time and effort that you put in to build that. It's really the foundation that enables so many other things. Okay, great. Couple extra questions rolling in here. We'll try to get to them. Have you looked at how midwifery can be a part of your team? For example, there's some abbreviations being used here that I don't know what they are, but home visits, immunizations, pap smears, and other basic care.
So we haven't looked at that yet. I can tell you each month that we added on a new healthcare professional in our office is a big task in and of themselves. As a physician lead, going, okay, I know that the social worker, for example, can do all of these things, but what do they actually do? And what can we do to fill their time while we figure out how they're best suited? So, there's time up front. And I think it's a matter of time that we're getting more healthcare professionals. I think midwifery is an excellent example. And if you are a midwife, something that you should advocate for yourself and look into doing something like this and reaching out to a family physician office as well.
Great, thank you. And thank you, they've clarified prenatal visits and postpartum care. Thank you for that. I should have guessed that, but didn't quite know. Someone else here is asking about the nurse triage algorithm. Would you be able to extrapolate on this tool as well as the process you use in the clinic with the team to develop and tweak it?
Yeah. So essentially, at 8 a.m., the phones open for our patients, and
Mm.
previously, their patients can call and be on a cancellation list for a same-day appointment. There are some same-day appointments reserved. Previously, we didn't know what the presenting complaint nor the details, and so what was happening is it might be, I want to see my physician. Last week they sent all these scripts and forgot one, like things like that, that were just a total waste of a visit. Now, this cancellation list that's accumulated, the patients kind of get put into the nurse's schedule. They phone them back one by one. They gather more medical history. We use things like macros for some of the 811 protocols. So, for example, when nurses that are on for 811, so patients phone in about concerns whether they need to see their provider or not and ask questions. Similar, they gather all the details like they would in that, for different presenting complaints. And just like in those protocols, there's urgency associated with certain things and how they answer. So if they're, emergent, like this person's got chest pain and they can barely talk to you on the phone, well, the nurse is actually just going to divert them to the ER because the office is not appropriate. Down to, this is probably needs to be same. It's a day, like it's a kid with, fever for a few days and they're not feeding well or etc. Let's fit them in. Or, I've had a mole for 1 year. I want to get checked out for. It hasn't changed for 1 year. Like this can be tasked to the physician to book them in later. That's essentially what they're doing. And if there's any gray area, because yes, the triage algorithms pick up things for the most part, there are areas of uncertainty that we encourage, the nurse to go seek out the doctor of the day and run it past them. What would you do in this situation? How can we accommodate them? And there's learning, both ways, on physicians providing feedback on, okay, what more questions should be asked? What do I want to know? And the nursing going, I feel more confident, triaging this in the future.
Great, thank you. Yeah, a couple of things that stood out to me about that are number one, the concept of stealing shamelessly. 811 has the macros and the templates. Let's try those. And the other being, that great combination of standardization and customization. So we can use an algorithm to pick up a lot of things, but there are areas where we're asking people to use their judgment, and there's room for both in there. It's not, completely cookie cutter.
So
All right.
we have
Oh,
some
sorry,
people
go
that
ahead.
are requesting about can they use these tools? Can I see?
Yeah,
Give me an email. Give me an email. I'll
great.
help you out.
Oh, thanks
Perfect.
so much for that. And actually, I was going to suggest that. So there are so many questions in here now that I think I can pick one more, but I won't be able to get to them all. But you have kindly offered and shared your contact information for people to reach out with questions, and thank you so much for that kind offer. So I would encourage people, if you have questions, to please follow up with Dr. Harrison. The one I'll ask is curiosity about how the physicians are using that saved time. So you talked about the number of appointments you've saved. What are physicians able to do now with that time?
So some of those are just booked in with other patients
Yeah,
that were previously, it might have been 4 weeks to get in to see your family physician. It might be 3 weeks. So we are not yet have a good process for looking at the third next available visit. But that is something that I think we want to look at because it is improving. And sometimes those visits are just filled with paperwork. Family physicians are burdened by a lot of administrative work. And so not only with this pilot are we hoping to get some of this administrative work completed by the physician themselves, but offloading it to other professionals too, so that there's more satisfaction at work.
great. All right. I think I'm going to have to wrap it up there because we just have a few minutes left. So, Dr. Harrison, I just again want to give you my sincere thanks. Your time is very valuable, so thank you for spending an hour of it with us today and sharing your story and your improvements and your kind offer of, speaking to anyone who's interested about the great work that you've done. And just thank you for your championing of improvement and your dedication to serving your patients better. I'm really excited to see what you and your team accomplish into the future.
Well, thank you, Tracy, for having me. It's been an honor and something I've been dreaming about doing for a
Oh,
while is coming to speak at this. So I, it's been an honor, really. So
excellent.
thank you very much.
We've been very happy to have you. I just have a few more slides just to wrap up the session, so please all just bear with me for the last few minutes. You will be receiving Dr. Harrison as a small token of our thanks, a pair of I Heart QI socks. For those of you out there who desire your own pair of socks, we'd love to hear from you. If you have ideas that you would like to share on QI Power Hour, please share them with us. We're always looking for new speakers who have interesting ideas and concepts and stories to share with our listeners. So please do feel free to reach out to us if you have a topic you'd like to pitch. We also would like to continuously improve our QI Power Hour offering. So when you leave the session, you will be redirected to our survey provider to answer a short survey. Please do take a few minutes to do that. We do read all of the feedback that we get and do our best to act on it. And you can trust that it's not taking you anywhere sketchy. So please feel free to click on that link and share with us your feedback about how we can be doing better. And we are hard at work on our next QI Power Hour session. We don't have that quite nailed down yet, but please do visit our website to look at the upcoming sessions, sign up for the newsletter, and watch previous sessions. You can also sign up for our Health Clips newsletter while you're there. And please do join us next time. In the meantime, everyone take care, and we look forward to seeing you again soon. Thanks so much.